Hello, everybody. Today we're going to talk about rheumatoid arthritis, a condition where the immune system mistakenly attacks the joint, causing inflammation, pain, swelling, and stiffness. So let's dive deeper into the condition, but don't forget to hit the subscribe button. So here we will take a look at citrullination, which is actually a physiological process, but it is also observed in the pathogenesis of rheumatoid arthritis. And this occurs when the amino acid arginine is converted into citrulline with the help of the enzyme peptidyl arginine deaminase. In certain structures such as vimentin and type 2 collagen, which we might find in synovial membrane as well as cartilages, because these are target cells for rheumatoid arthritis. So the enzyme deaminase would help remove the amine group right here, and this will help us achieve or obtain the peptide citrulline, which is of interest in the pathogenesis of rheumatoid arthritis. So in the context of rheumatoid arthritis, the process of citrullination leads to the formation of these citrullinated peptides, which then triggers an autoimmune response in a genetically susceptible person with HLA DR1 or DR4. Now, this is even more stronger if the patient has risk factors such as smoking or they have sustained some infections in the past. Although infections are implicated, there has not been any evidence of retrieval of microbial DNA from the joint tissues. But however, there is a bacteria by name Porphyromonas gingivitis, which colonizes oral cavity of patients with periodontal disease. And this bacteria has been shown to possess an enzyme that can actually cause citrullination of peptides. This sounds interesting. So let's get back to the peptide citrulline, which is of interest to us. That is then recognized by autoantibodies, such as anti-citrullinated protein antibodies, which I would be referring to as ACPA. So these antibodies, of course, they will be present in the serum or in the synovial fluid of patients with rheumatoid arthritis. And after the autoimmune response, a subsequent inflammatory response, which then contributes to the destruction of the joint structures such as the synovial membrane, the cartilage, the bones, and the surrounding tissues, or even the extra-articular tissues. So ACPA has a specificity of around 98%, which is very, very substantial and good in the diagnosis of rheumatoid arthritis. And it may even be detected many years prior to the onset of rheumatoid arthritis, which we call the preclinical phase. So it's important to understand that the changes or the citrullination can change the charges of these proteins. In fact, arginine is positively charged and peptidocitrulline is a neutral charge. This can lead to changes in the protein to protein interaction and lead to an autoimmune reaction. All right, so here is a depicted simple diagram of a normal joint, and you can see some of its major components, the synovial membrane. This is a thin layer of cells that lines the joint capsule. It offers several important functions, provides lubrication for the joint cavity, which helps reduce friction. It also offers some level of structural support to the joint and provide nutrients for the cartilage. On the other side, we can also see the cartilage. This is made up of mainly type 2 collagen, glycosylated proteins. It offers an important structural support for the joint, helps withstand impact and stress, and distribute it evenly across the joint. So it is important to note that the cartilage lacks vascular supply. So the synovial fluid provides some level of nourishment for the cartilage. The joint cavity we see right here, this may also be a site for effusions in the joint occasionally in patients with rheumatoid arthritis. We also see the bone that can be affected in rheumatoid arthritis as a result of excessive bone resorption that leads to bone erosions, loss of joint space, osteopenia, in other words, distraction and damage to the bones. So the synovial membrane initially remains the major target in rheumatoid arthritis, which eventually extends to the surrounding structures as well as the extra-articular tissues. All right, so now we know that citrulline is targeted by the immune cells. So let us say an antigen presenting cell right here. picks up the citrullinated peptide and then presents it to the T cells. This is very important. T cell activation is essential and crucial in the pathogenesis of rheumatoid arthritis. So there is a process of sequential signaling. Some signals will come from the antigen presenting cells into the T cells. This, in fact, is much more complex than what is being described. So that signals to the T cells to get them activated. That process is known as co-stimulation. So co-stimulation, in summary, activates the T cells. If co-stimulation is not strong enough, then the T cells eventually becomes tolerant or they may undergo cell death. So sequential signaling can be targeted pharmacologically to interrupt T cell activation. A drug which is known as abatacept is a biological agent that may be used to interrupt the process of co-stimulation. So in short, both the T cells and B cells play a predominant role in rheumatoid arthritis. When B cells are activated by the T cells, you can see it right there, B cells differentiate into plasma cells. Plasma cells would also help produce immunoglobulins, and these immunoglobulins help contribute to more recruitment of cytokines into the site of inflammation. So B cells may also express a CD molecule, that is CD20, on its surface. If we are able to target this molecule and inhibit it, we can actually inhibit the activity of B cells. Rituximab is a drug that is used for that purpose. Macrophages also gets activated right there by the T cells. So the entire process described leads to the formation of a cytokine and chemokines. This may include interleukin 1, 6, 17, TNF alpha, as well as gamma interferons. Interleukin 8 may even drive neutrophils into the joint cavity. In general, there is an acute phase response. So clinically, you may be seeing an elevated erythrocyte sedimentation rate or a C-reactive protein. Cytokines may cause systemic features such as fatigue, fever, or even malaise. Angiogenesis is also enhanced through vascular endothelial growth factor, which helps support the persistence of inflammatory cytokines with its extensions to the extra-articular tissues such as the lungs, the heart, brain, skin, the renal system, or even erythropoiesis. So cytokines and chemokines can lead to a synovial membrane proliferation. There is also release of protease enzymes from these destroyed membrane, which we call pannus, and this leads to a subsequent joint damage. So normally the synovial membrane is made up of a thin layer of cells. Now in contrast, in rheumatoid arthritis, the synovial membrane gets infiltrated by T, B cells, macrophages, fibroblasts, mast cells, and osteoclasts. This causes the synovial membrane to become hypertrophied. So the cells infiltrate and then the synovial membrane then becomes very thick. It even swells and thickens, and this is often referred to as pannus. So, pannus is something that you would see in rheumatoid arthritis. Now, pannus causes a severe chronic inflammation that consequently damages the synovial membranes, the cartilages, the bones, or even the surrounding tissues. Protease enzymes, which is then released from the pannus, can also cause further damage to the joint. In rheumatoid arthritis, osteoclast, which we have right here, becomes activated. On the surface of the osteoclast, there is a rank receptor. These rank receptors can be activated by a ligand on the T cells, which is rank L. The interaction between these two would lead to an activation of the osteoclast, which would lead to excessive bone resorption and erosions or destruction of the bone. Now, hepcidin is also elevated in the face of excessive cytokine production. This would help trap iron into macrophages, making it unavailable for erythropoiesis. So, what is rheumatoid factor? Here you can see the pentameric configuration of immunoglobulin M antibodies. When this is directed against the Fc portion or fragment of the immunoglobulin G, the complex that is formed is what we call rheumatoid factor. In fact, this is present in 60 to 80% of the cases. So this is non-specific. That is to say that rheumatoid factor can also be found in some people without rheumatoid arthritis. Particularly, this is very true for those who have had previous infections such as hepatitis, tuberculosis, chronic liver disease, chronic kidney disease, or a lymphoproliferative disorder. It can also be associated with Sjogren syndrome. Rheumatoid factor, however, may be used to monitor disease activity. Diagnosis. So, according to the American College of Rheumatology and the European League Against Rheumatism, they have developed a point system that helps with the diagnosis. This emphasizes on the clinical evidence of joint involvement, serology evidence, the presence of acute phase reactants, and the duration of the symptoms. So, we will start with the clinical evidence of joint involvement. And here we want to emphasize that there should be at least one joint with convincing clinical synovitis not attributed to another inflammatory disease such as gout, psoriatic, or lupus arthritis. So, in general, this may include joint stiffness in the morning that lasts for more than an hour. The joint may be warm to touch, swollen, and very painful. Generally, this may affect the patient's quality of life. So, if a patient has one large joint, they get 0 point. A patient with 2 to 10 large joints, they get 1 point. Patients with 1 to 3 small joints will have 2 points. Patients with 4 to 10 small joints will have 3 points. And finally, patients with greater than 10 joints, that includes one small joint at least, they get 5 points. Now, serology evidence. So, if patient has rheumatoid factor as well as anti-citrullinated protein antibodies negative, they get 0 point. Depending on the titer, if a patient has a low positive or a high positive rheumatoid factor and ACPA, they get 2 or 3 points respectively. Acute phase reactants. If C-reactive proteins as well as erythrocyte sedimentation rate is normal, patient gets 0 point. If these parameters are deranged, patient get 1 point. There should also be some self-reported duration of signs and symptoms. If this is beyond 6 weeks, patient gets 1 point. All right, so let me also show you an easy way that you can remember the parameters for this classification criteria. So you can just use the mnemonic SCARE, and you will deduct from this mnemonic. S means a symmetrical pattern, a swollen joint, and stiffness. This, in fact, is a clinical evidence of joint involvement. C is C-reactive protein, which is an acute phase reactant. A is an anti-citrullinated protein antibodies, necessary also for the diagnosis. R is rheumatoid factor, and ESR, which is also an acute phase reactant. Now, regarding the self-reported duration of signs and symptoms, you can also say that the S is for 6 weeks, right? And if you write 6 weeks, if patient has less than 6 weeks, they get 0 points. If a patient has 6 or more weeks, they get 1 point. So I think this is an easy way to remember these parameters. So generally, you would also like to look at the hematology. A complete blood count will help you find anemia of chronic disease, granulocytopenia. Pelti's syndrome is a triad of neutropenia, rheumatoid arthritis, and splenomegaly. So platelet impairment may also be associated with rheumatoid arthritis. Regarding imaging, an X-ray, an ultrasound, or MRI may be used. Of course, MRI has a very good sensitivity. In cases where there are cyst formation, an ultrasound would also be very useful. So this will help you find soft tissue swelling, osteopenia, joint erosions, loss of joint space, subluxations, for example, in the Atlanta axial joint. So let's take a quick look at the differences between a swan neck deformity and bottom-neck deformity. So swan neck deformity has a flexion in the DIPs. You can see that there is a flexion and there is a hyperextension in the PIPs. In contrast to bottlenecks, we see a hyperextension in the DIPs, but we rather see flexion in the PIP. So this is a simple way to discriminate between these two deformities. Management. So here we will be using disease-modifying anti-rheumatic drugs, and methotrexate remains the first line. This drug stimulates the release of adenosine, which suppresses inflammatory response from immune cells. They also possess anti-proliferative as well as immunosuppressive effect, and they increase T cell apoptosis. Now, you also recall that folic acid is converted into dihydrofolate, and dihydrofolate subsequently converted into tetrahydrofolate. So the drug methotrexate would block this reaction, that is the conversion of folic acid into dihydrofolate. So you would like to administer or give the patient folic acid, and this is usually 5 milligrams of folic acid on the morning following the day of methotrexate. Methotrexate also has some side effects such as GI tract impairment, inflammations of the oral cavity, cytopenia, interstitial pneumonitis, and hepatotoxicity. Now, regarding this, you would of course like to do a CBC, that is a complete blood count, let's say 4 to 8 weeks, to review and make sure the patient does not have any of these side effects. A liver function test and a renal function test would also suffice. Two more necrosis factor inhibitors. Infliximab is a monoclonal antibody that inhibits TNF alpha. You need to watch out for the reactivation of latent infections, hence screen for latent tuberculosis and viral hepatitis before initiating these agents. Etanercept is a soluble TNF receptor 2 Fc fusion protein that also neutralizes TNF. Adalimumab, golimumab, and certolizumab pegol are among the agents that may be found in the market. Rituximab is a B-cell inhibitor. Anakinra and tocilizumab are interleukin 1 and 6 inhibitors respectively. Hydroxychloroquine sulfate. The use of hydroxychloroquine should be reserved for patients with mild rheumatoid arthritis. It may cause pigmentary retinitis, hence a 6 to 12 monthly ophthalmological review is recommended. Corticosteroids. The use of corticosteroid is only preferred as a short-term agent during the acute phase of the disease. In articular disease, a greater than 10 milligram prednisone or equivalent is inappropriate. Sulfasalazine, leflunomide, and azathioprine are among the agents that may be used or combined, and gold salt has a history for the treatment of rheumatoid arthritis. Thank you, and I hope this was useful. If you enjoyed it, then hit the like button and subscribe to the channel. Bye.